So thank you. Those of you who are coming here for the first time and for those who were there for the last session. So a hearty welcome from all of us at AVN. Thank you very much for taking your time to join in. Um, we will try to do our best in terms of adding value to your clinical practice. So I've tried my level best to keep the most relevant content here. In the meanwhile, still, if you have, I mean, I'm going to present. If you have any questions or any doubts that you would like to raise, please raise them in the chat, and Dr. Dilip will consolidate them, and now I will try to answer all those questions towards the end of the session. With this introduction, I think we will start. So today's topic, comprehensive Ayurvedic management of low back pain, is actually a very common topic. You might wonder why we want to choose this topic itself, because I think one of the most common conditions for which people come to an Ayurvedic treatment center or to a doctor is low back pain. We all know that, but then why a webinar on that? So the basics, the fundamentals of what low back pain is all about, I think all of us are aware. I'm just trying to see if we can add some value to, the fine tuning of what we can do. How can we do things better? Some points which we might have missed out, some points which we have not been exposed to. So maybe I'm sure I've tried my level best to stuff in things that can add value to everybody. If there is anything missing, or you want more information or anything of that sort, even for that, you can feel free to put in your comments in the chat box, so that we'll try to consolidate all that and take those inputs into fine tuning how we are doing things in future. Even in terms of feedback, you are welcome to please give us feedback on what you liked, what you would like to see different, etc., etc., and we will try to that will help us to actually improve what we are doing out here. So with this short introduction, I will plunge into the topic. I don't want to spend more time on this topic. Yeah. So now we all know that low back pain is a very common condition. It's a very pervasive global and an Indian healthcare challenge. So statistics say that actually the incidence of low back pain is increasing, not just with proportion to the population, but even faster than that. And it is categorized as the number one cause of skeletal-muscular disease burden and disability worldwide. Why people lose their ability to live their life in a productive manner? One of the major causes, the skeletal-muscular disease burden, so which takes away productive life or active life from people's overall lifespan. Back pain, low back pain, is one of those very important causes worldwide. And the disease burden, if you are measuring it, it is actually by years lived with disability. That is the index used to measure how many years. So on an average, this was a survey conducted in the year 2019. It is shown that about 7.41 years are spent living with this disability. If you are taking the people who are, living their lifespan, they are saying a large volume, that is 7.41 total years are lived with this disability on an average at a global level. So that is the very important point. So we all know that back pain happens to everyone at some point in their life, but it's very critical to understand that so many years are actually lost to of productive life, where you are able to move around, take care of yourself. That is one of the primary requirements of all patients, and that is seriously affected by low back pain. So that, I think, if this can slightly change our perspective on low back pain, rather than just looking, or we are often too occupied by that acute manifestation of low back pain, but we fail to recognize the long-term impact of low back pain, whereby so many millions and millions of people are suffering lifelong. Absolute incident cases projected to rise from 223 million to 253 million globally by 2030. So you can see what a phenomenal global health challenge this condition is posing to the world. So that's the context that I want to say. So any amount of work that is already happening, the amount of research or whatever the medication and the protocols that are already available constantly need to be upgraded, fine-tuned, made better so that the impact of this disease on the world can be lessened, and the number of years people have to spend in an unproductive manner or feeling very desperate and dependent on somebody, that can be dramatically reduced. So that is the intention of this webinar. Now, the condition in India is not very different. We are the second largest country in the world. Of course, that is in proportion to the population. That China is the world leader in terms of back pain cases, and next to China, India is the second largest country with the topmost number of cases, and next is the US. So together, the three of us together account for 37% of the total number of cases worldwide. India faces a disproportionately high burden of low back pain, ranking among the top countries. This is what we said. So very high global ranking and demographic variation. That is the other thing. Different categories of people. For example, gender-wise, there is a preponderance of suffering in the women as opposed to men, and so on and so forth. So there are several details on that. I don't want to go too much into that statistics. We are not public health people so much, but then just to have that overall idea, there is a difference in the rate at which back pain is prevalent in society. And the most important thing is that because of the widespread incident, it poses both a critical public health challenge and a significant socio-economic burden. Because when people are not independent, it's a burden on the caretaker as well, and the entire the financial stability of the family, as well as thereby the entire society is put to risk when people have got a burden of disability which they have to counter. So knowing that this sort of back pain is something that we need to be aware about, and what can we do in order to avoid or prevent or reduce, at least reduce the incidence of this level of back pain. So that is the challenge to which we are trying to find answers. Now, on this background, so this sort of incidence and this itself, straight away, because worldwide the biggest system of medicine that is handling this is the conventional allopathic medical management. And there we find that there are some serious limitations. The number one is, even today, the treatment approach is totally focused only on the symptom. So modern medicine is still very much focused on how do we give pain relief. So that is the only thing that is happening in modern medicine. They don't even have a clue as to how to handle the root cause of the problem. So it's still at a very superficial level that this disease is being handled. And thereby itself, the corollary to that is that it has got a very short-term efficacy. Many interventions provide only temporary relief with diminishing returns over time. Initially, a painkiller works, but if you keep using it after some time, of course, in addition to the side effects, which is the next point, even the benefit that you get from the same pain relieving medication keeps coming down. And once you sort of stop it, then there is a rebound pain. You get extra pain that happens on discontinuing the medicine. So in short, while painkillers are a good solution for a short-term, small problem, but for a chronic problem, it is what makes the problem even worse. And the corollary to that is, because people are suffering, they will tend to use pain medication more. And even if used according to prescription, the long-term use of NSAIDs, muscle relaxants, and opioids carry significant risk, including gastric, hepatic, renal, and dependency concerns. So people also become dependent on painkillers. There are several people who have to take it, if not for anything else, at least for their psychological well-being. So these are some of the serious. In addition to that, of course, we are all aware of the surgical overutilization. Surgery is touted as an option when things are bad, when the pain is more, when the pain is severe, and indiscriminately surgery is being recommended and done. So procedures are often recommended prematurely with high rates of failed back surgery syndrome. So that itself is called as a syndrome, back surgery failure syndrome. And post-surgical complications, there are several complications as well. So that is a very serious limitation of what conventional medicine poses in the management of back problems. Then comes the mind-body disconnect. Of course, that is there with almost all approaches in modern medicine. Even now, the modern medicine is not really put together, though conceptually it is there. In practice, very often the mind-body connect is not at all factored into this thing. And there is a lot of psychosomatic effects and lifestyle factors contributing to persistent low back pain. This is something we'll also be seeing in the course of the presentation, and something that we absolutely need to be aware of while managing patients with back pain. So these are some of the major limitations of conventional medicine. So in this background is how we are going to look at what role can we as Ayurvedic medical practitioners play in this whole scenario. So looking at this scenario, we can very clearly see some dramatic challenges and opportunities. Number one, we know of the challenge in terms of high incidence, rising number of cases in OPDs across urban and rural areas. So that's a big challenge as well as an opportunity. Of course, any challenge is actually inversely an opportunity as well. So because there are more people, there is a bigger responsibility, there is a bigger opportunity to develop better solutions and to deliver better care. The chronicity is very important challenge. So increasing recurrence rates and long-term complications. So people keep getting back pain again and again. They would have got an episode of back pain, some treatment was done, or even naturally it got better, but then again it keeps coming. It keeps coming more frequently over a period of time, and then it starts becoming permanent. So this is one of the trends that is seen in low back pain, and that itself is a very important complication. The third one is the treatment gaps, as we saw earlier, the mainstream medicine, the limited long-term relief with conventional care approaches. So I think this is what is one of the big challenges in modern conventional medicine, and that itself provides a great opportunity for us as Ayurvedic health practitioners. So our role here is to be able to provide functional and sustained recovery through holistic management. So I think that is the biggest opportunity for us. That, because modern medicine is not really capable of addressing it at that level, and it falls short on many fronts. But we must also be careful that we don't fall into the same trap as well. Our idea about the treatment, the way we also, make the customer or the patient aware about the issue has to be with that sort of outlook that, you need to be focused on the functional and long-term recovery, not just relief of pain in the short term. So with this background, let us try to understand more about low back pain. So as we all know, that is the benefit that we have got as Ayurveda. So as a concept, we all know that Ayurveda believes in this holistic perspective. We are not really just looking at the pain relief. We are trying to go deeper into the causation circle. We are trying to go deeper and deeper. And the deeper you go, the better off your solutions are, because that's what really distinguishes us. And of course, we all know, I don't have to talk much about the personalized care, which itself is the primary paradigm in Ayurveda. Though, of course, we can talk a lot about personalized care, very often we are also sort of personalizing only to a limited extent due to practicality. And even the patient, sometimes there are limitations from both the patient as well as from the situation in the whole this thing. But nevertheless, there is still a lot of room for us to personalize, and at least to the extent of not just putting all back pain into one bracket. There are a lot of subtleties, a lot of finesse around at least the different avasthas, the different this thing, and accordingly, how can we fine tune our treatment? Of course, then we are blessed with this time-tested wisdom about how the body works and how we can rebalance our doshas. And last but not the least, the big opportunity which is there in front of us is to have this integrative approach. Because I am one who believes that the Ayurvedic concept is so broad that it does not exclude anything. Within the gamut of Ayurveda, we can understand everything from just a suggestion or a conversation with the patient to surgery, because even we are not antagonists of surgery. We had the father of surgery from our own branch, Ayurveda. So, I mean, everything from just speaking to the patient and reassuring them up to surgery, nothing is out of bounds for an Ayurvedic doctor. So that is why I think Ayurveda is a system that can really give us the platform for a fully integrated approach towards management of any condition. So these are the advantages or the positioning that Ayurveda has and the advantages it has in handling this particular problem. Now let us come to the overview of the low back pain management in Ayurveda. Generally, what is happening? So we understand skeletal-muscular low back pain in terms of many terms. We understand the terminology Kati Shula. We also understand Kati Graha, Gridrasi. So these are some of the three words which are directly correlated with spinal and back-related problems. So these, I'm not going into the depths of this understanding definitions, etc. As Ayurvedic doctors, we are all quite familiar. And we also know that Amavata or Amanvita Vata Rakta can also manifest as back pain. Why I'm calling this as two different, or means I am aware that in the different parts of the country, what we refer to as Amavata and Vata Rakta are two different things. But in my perception, Amavata is also a sort of a Aman with a Vadarakta condition. So I'm just clubbing both into one common umbrella for the purpose of the clarity, which is why I'm trying to mention that upfront. So we know that though that is the back pain is not the characteristic or the most distinguished sign or symptom of Vadarakta or Amavata, but still it can also be one of the major manifestations that come through in that manifestation. So from a clinical perspective, we all know that all these are Vata Pradhana conditions with importance to the Apana Vayu as the subdosha. So Vata disease, I don't think there is any controversy. Everybody categorizes it as a Vata Pradhana Vyadhi with Apana Vayu being the subdosha. The only exception is in this case is the Amavata related back pain, where the importance of Ama is very, very great there. We don't just look at the dosha Vata alone, we also look at the Ama as a very important causative factor. And also Vyana Vayu is also involved. It is not just restricted to the Apana Vayu. It is more, global. It is much more, it's a full body systemic phenomenon, which can be, categorized between Vyana Vayu and Prana Vayu, for example. So the critical diagnostic consideration is primarily to evaluate the presence or absence of Ama. So when we are treating a patient with back pain, I think the first consideration in the mind of an Ayurvedic doctor has to be to look at whether there is an association of Ama or not. And the therapeutic strategy is then decided accordingly. I mean, I think that is a very common background that we all know. So it is again wrong for us to assume that all conditions have got only this or that, so that's where understanding that these two possibilities are there. Even in a degenerative disease, primarily, there can be an avastha where there is an Ama association. So one of the important considerations is to look at the presence or absence of Ama. The therapeutic strategy is then decided accordingly, which means if you are seeing the absolute absence of Ama, Kevalavada Chikitsa is the main thing. I'm not going into exactly which procedure, etc., which we will be covering later. But in short, it is the Kevalavada Chikitsa, the Siddhanta or the Sutra, which we can apply for a pure degenerative disease. Whereas if it is an Amanvita condition, for Amavada Chikitsa Paddhati is the one that we will adopt in the case of the presence of Ama. So this is at the topmost level, 40,000 feet level. What is our treatment protocol? I mean, this is how we need to first divide the two scenarios. Now, given this, I'm sure all of us as doctors are treating back pain with a very good success. But we might have a few cases of challenges, few instances where things don't work, etc. So the attempt is to try and see, can we pick out those situations and avoid that problem from manifesting in future. So look at, so if we are looking at that as our challenges and opportunities, the way I look at it is, number one of the challenges is we need to understand the exact nature of the condition. Now, if we are looking at it just as a Vata Pradhana disease or view of the condition, but we have to go deeper into the condition exactly, which is where modern medicine has come out with so many different and specific conditions that are causing the back pain and so on and so forth. I think that not understanding that subtlety of what is causing the back pain, I think is one of the causes of lack of success or complications that happen within our treatment when we are handling patients of this problem. The other issue is distinguishing between conditions that can be treated conservatively and those that require urgent surgical intervention. While majority of these problems can very well be treated with conventional, non-surgical interventions, there is a small subset of these diseases which definitely need surgical intervention. So if we miss out on identifying those situations, that can be a major disservice that we do to the ailing humanity. So that is another very important challenge that we as Ayurvedic doctors face. I mean, this is what I have felt. So I'm just sharing my experience with you. I'm sure you all have wide experience on all this also, you are welcome to share your perspectives on the chatbot, which will also be helpful for us to, have that sort of interaction going. Then we come to, so given this sort of a challenge, that itself is the opportunity. So understanding the different causes of low back pain and the exact details regarding how the disease progresses will help us in providing accurate prognosis. For example, a patient comes with back pain and asks us, how long will it take? Will I be definitely cured? Is your treatment very, very successful, etc.? If we are just identifying it as a back pain with AMA, without AMA, we are not in a very strong position to provide a real accurate prognosis, or even in developing appropriate treatment strategies and fine-tuning the treatment. So this is what my attempt is, to try and help us to create a sort of a framework in which we can not miss out on these opportunities. It can also help prevent loss of valuable time, to prevent irreversible damage in certain cases, because not undergoing surgical intervention at the right time might be irreversible in very few cases. Though the condition may be numberless, we may not be getting many of those cases also. But in remote settings and in different settings, I think the challenge is different. But if we were to get a patient who definitely needs a surgical intervention and we don't do that, that will be a big disservice that we do to the patient. So I think that is one of our important responsibilities. But it also, that sort of knowledge will also put us on a different pedestal of more credibility, more trustworthiness, which is one of the very important things going forward. So on this background, we would like to understand the low back pain causes more detail. I'm sure all of you know this, but many of it may be just repetition. But if you can get 1 or 2 points extra, I think it will be worth it. That's what my attempt is, because low back pain is such a condition which every person is treating. So, please don't get bored up if I'm saying things that are already known to you. So we all know that there are many, many categories of, conditions that cause low back pain. We can categorize them into 5 basic categories. One is mechanical causes. That is pain related to movement or posture affecting muscles, ligaments, and joints. So movement resulting in pain, suddenly lifting weight, suddenly jerking in a vehicle, etc., etc. So mechanical causes of pain. Then there are the degenerative causes of low back pain, age-related and premature changes in the spine structure, including the discs and joint degeneration. This is another sort of a category of causes that results in low back pain. Then we have the neuropathic, pain arising from the nerve compression, inflammation, or damage in the lumbar region. Okay, it can be due to that, neurologically mediated pain, like in the case of sciatica and so on and so forth, radiculopathy, myelopathy, and those sort of symptoms that happen due to neurological involvement in the situation. Then there are these systemic diseases like secondary to other health conditions affecting multiple body systems. It can be systemic inflammatory disease. It can be multiple conditions which are more systemic in nature, not just localized to the back. That can be a cause of low back pain. And last but not the least, very important factor is that it can be psychosomatic. Pain influenced or exacerbated by psychological factors is a very important factor, and mental stress. So this is another category of causes which produce low back pain. Let's understand them in detail. So mechanical causes include muscle strain, ligament sprain, etc. So if somebody is sitting in a posture for too long, that is not used to, that muscle becomes overused and that gets into fatigue, and that can cause pain. It can also come from lifting something. Suddenly, one muscle is suddenly put into a jerk and then there is a small tear, etc. That is called as sprain. And strain is when a muscle is put to overuse. So these two conditions are very common mechanical causes. We have postural imbalances resulting from prolonged sitting and incorrect ergonomics. Sitting in a not good chair, not supporting the lower back. And also we are sitting in a very inclined position, like that. These are all the causes of low back pain. Dysfunction affecting the connection between the spine and pelvis. So the sacroiliac joint is not really articulating well. That can also be a cause of mechanical cause of back pain. And abnormal spinal curvatures like hyperlordosis, scoliosis, kyphosis, etc. So the spinal curvatures being abnormal. These are all causes of mechanical causes of low back pain. The most common cause of low back pain is actually muscle. See, we must remember that there are so many muscles that are involved in keeping the back and the pelvic region stable and moving. So these muscles, when they get into contracture, they get into spasm. That can be the most common cause of low back pain. Very often, people, even before they come to us, that pain would have come and it would have gone. Today, people have access to pain medication. They will immediately resort to something like that. So we don't see many of that. But the largest percentage of patients who are suffering from low back pain actually have muscular problem and these mechanical causes as the cause of pain. And it's self-limiting as well. Most of that will go away within a very short time, but sometimes they get panicky and they can come to us, but we need to deal with that. The most important thing which definitely needs treatment and which is largely unattended or for which there is no big solution is the degenerative spine disorders. The classical area of intervention for Ayurveda, degenerative spine disorders, including lumbar spondylosis, which means age-related degenerative changes in the lumbar vertebra and the intervertebral disc. So intervertebral disc is called so many conditions which we have put here. There is a normal disc, there is a degenerated disc, there is a bulging disc, there is a herniated disc, there is a thinning disc, and completely damaged with osteophyte formation. So this is typical spondylotic changes, degenerative changes that happen to the bone and to the discs over a period of time. There is the other thing called as a facetal joint wear and tear. So this is the facet joint where one vertebra articulates with the other, which is permitting us to make this lateral, this sort of a movement is possible because there is that joint permitting us to do that. Those facet joints, they are like a typical articulating synovial joint, which can be subjected to osteoarthritis. And those, for example, like the one you're seeing here, this is the basic vertebral, but if the facet, this one is also inflamed, this is the region through which the nerves are emerging. And when the facetal joint has got osteoarthritis, it presses on the emerging nerve, which can also cause same radiculopathy and stuff like that. So last but not the least, the canal through which the spinal cord passes is sometimes compressed because of the thickening. Because to keep this vertebrae in position, there is the posterior longitudinal ligament, the anterior longitudinal, which is not of much significance, but the posterior longitudinal ligament, which runs along the length of the spinal canal on the posterior of the vertebral body, can become thick with the time, and that can cause canal stenosis. Canal can also get stenosed because of the osteophytic formations. So bony, discogenic and ligament related compression, reducing the space within the spinal canal, results in spinal canal stenosis. So these are all typical manifestations of degeneration in the spine. So to understand, because the disc is the most important thing that is getting degenerated in this process, we understand bone degeneration when we did the class on osteoarthritis. So I'm not going into that in detail, but let us try and understand what is really happening to the disc. As we all know, the intervertebral disc, this picture is showing you that it's a white gelatinous substance that is there overall as a disc. If you can see this is made up of two regions. One is the outer region called the annulus fibrosus, which is comprised of fibrous tissue, and the interior portion is a gelatinous substance which is known as the nucleus pulposus. This disc is one of the villains in most of these issues. And the disc does not, there are certain characteristics which we need to know. The disc does not have blood supply and depends around the surrounding fluids for nutrition. Just like I mentioned about the cartilage during the osteoarthritis class. This one does not get direct blood supply. So the nutrition is coming only from the pressing and relaxing which is happening to that. So the fluid that is surrounding actually gets imbibed into that, and that is what produces the nourishment. So which is why people who are not having activity also suffer very badly from disc related problem, because if there is no movement, the nutrition to the disc becomes lesser. Sedentary lifestyle, that is why it aggravates or accelerates disc damage. So even over time, naturally also what happens is over time, the water content, this has got a very high water content, because that water is what gives it the elasticity. This is the sort of cushion. We don't have the cartilage between the bones here in the vertebra. It is this disc. And this disc Once it loses water, the elasticity of the disc is lost. And that condition where the water content in the disc is reduced is called as a disc dehydration. This can be seen from an MRI, which I will be showing you how we can identify. This is then it is less capable of absorbing the shock due to movement, and it loses height. When the elasticity is lost, so when the pressure is happening, it is not bouncing back to its original size or shape. So slowly over a period of time, the height of the disc becomes smaller and smaller. So that condition, so while it is getting pressed, the height reduces and the overall size increases. So it starts bulging. Now this is the margin. Now if this disc becomes thinner, it will start bulging into this. And that condition is called as a disc bulge, which is an overall like a flattening of the disc. The reduction in elasticity leads to crack. So it's like, a very soft substance. If it is losing moisture, suppose you put it in the sun, it becomes brittle. It can then crack easily. This happens to the intervertebral disc and it loses elasticity, leading to cracks forming in the annulus fibrosus. This outer region, which is actually holding that disc in place, starts cracking up. And that results in the prolapse or the bulging of this particular gelatinous substance into the crack. And that condition is known as a disc prolapse or disc herniation. So for example, if this cracks open, this gelatinous substance will start, So this will start, pushing out through that crack. And that condition is known as the disc prolapse or herniation. The portion of the disc that prolapses may also get detached. Sometimes, it is prolapsed and then there is a large portion, and then with continuous pressure, that prolapsed portion of the disc detaches from its original thing and it goes and sits in some other place, and that condition is called as the extruded disc. From any position, it can go to another position, and that condition is called as the extruded disc. So these are some of the common descriptions we will see when we look at the MRI reports of patients, and that is what it represents. I am showing some other pictures also for us to understand it very clearly. For example, this is an MRI of a very young child. You can find that, there is a clear distinction in the disc level. There is a blackish interior and a whitish exterior. The color is not uniform. There is a two different shades representing the nucleus pulposus and the annulus fibrosus. Whereas with age, when it gets dehydrated, this whole region becomes black. This is not an MRI picture. This is actually a sort of a slice taken through that. So you can see here that this has actually the differentiation between the annulus and the nucleus pulposus is lost. And this is a dehydrated disc. On top of it, it has also created a radial tear. This tear is actually pushing out the nucleus pulposus into the exterior. And if you can see, though here you can see the crack is only there, it is not prolapsed because this margin is still intact. The ligament is not disc. You can see here that the nucleus pulposus is different from the annulus fibrosus. Nevertheless, there are some small tears that are developing. So there are in 3 dimensions, there can be tears. One is between the layers, there can be a tear. There can be a hole like tear inside, and also there can be a complete tear, which is called as a radial tear, as what happens here. Here you can see this is called as a circumferential tear. This sort of a tear will not lead to prolapse unless there is an opening like this, unless it opens. This is called a radial tear, and only a radial tear typically creates disc prolapse. Now, if you look at this MRI as well, very, very clear that, this disc is dehydrated while the others are normal. You can see the loss of this differentiation here, and there is a small bulge as well. There is a crack that has happened, a radial tear that has happened, and the nucleus pulposus is just, sitting here. It has not fully come out. Whereas here you see, this is a dehydrated and bulged disc. From this contour, there is a bulge here. This is called a bulged disc, whereas this is a normal disc. So this is how we can appreciate that. And last but not the least, in a degenerated disc, you can see this is a full prolapse that has happened. See here, these are small tears which are not consequential. You will not find any symptom because of this. But when the nucleus pulposus really comes out, then you can have real challenges coming up. So these are the advanced stages of, intervertebral lumbar spondylosis. What is happening is the disc is getting so degenerated, along with the bone is also getting degenerated. There is fatty degeneration of the marrow of the disc. So which means that the disc becomes, the bone becomes less strong. There is fat that is getting accumulated there. and the inflammation also sets up here. There is fibrosis and hyperemia that is happening. More blood flow is there, and that bone also becomes soft, and this is what makes it very prone to, even compression fractures. This coupled with osteoporosis is a very important cause of compression fractures happening in the disc. Even in the absence of fractures, the entire stability, and it also develops like osteophytes that are happening. The bone grows into the disc and the disc grows into the bone. This condition is called as osteochondrosis, where the bone and the cartilage become indistinguished and both of them are invading each other. So this is a very highly advanced stage of lumbar spondylosis. Lumbar or cervical, it can happen anywhere, more commonly in the lumbar region, that is called as osteochondrosis. We will look at some other conditions that happen along with this which cause severe low back pain. I'm sure we are all aware of the word spondylolysis. Spondoni pars interarticularis. So, for example, the vertebral body is sitting here, and then this process that is coming out, the articular facet, under that is the region called as pars interarticularis. This, so for example, this part here, it has been cut out to see this more clearly. So this is how that pars interarticularis area is here. Here, if there is a fracture, this is called as a spondylolysis. There are people who are genetically vulnerable to this. There is an area of weakness in this pars interarticularis. And suddenly, when a person is subjecting himself to sudden flexion, as in the case of playing a game, you're suddenly diving or something like that, that pars interarticularis can fracture. It will actually, what will happen is within a short period of time, the patient will recover. But generally, this is a non-healing fracture. This does not heal over time. But the patient will become asymptomatic. They will be moving on normally. It is very wrong to assume that he has fully gotten cleared. Actually, he has fractured the pars interarticularis, and this condition is known as spondylolysis. This can be congenital or induced, usually without clinical symptoms, or for a short period there may be some symptoms. Very often this is an incidental finding on radiograph. Only when you do an X-ray or an MRI, you will get to know of this. It is easy to be missed even in an X-ray. Unless you take it in an oblique position, very often you will not find a spondylolytic lesion very easily. It needs a lot of expertise reading radiographs to be able to detect a spondylolysis. So as you can imagine, when that breaks, the whole vertebra becomes a little, unstable, because it's like a full, one bone is like broken, but it is still held in position by the ligaments. It's like suspended by ligaments. So it does not move out and go off somewhere, but the level of mobility between the bones is altered. It can aggravate, and that itself causes instability of the vertebra. So this is a lateral X-ray. This is a normal pars interarticularis. This is an oblique view where you can see that there is a crack that has happened. So this is typically a spondylolysis. As I said, it's not very easy to detect. With practice and with continuous learning, we will be able to identify sort of a spondylolytic case even by looking at an MRI or an X-ray. The next situation is known as spondylolisthesis. Listhesis is a term that means there is a slippage. So slippage of one vertebra over the other is called as spondylolisthesis. It can be caused by a lax ligament. For example, the ligaments, as I told you, are the ones that are holding these small bones in place. Ligament become loose. When the discs lose height, suppose you imagine there is a stack of things that are tied together with a rope, and the stack of things become smaller. They shrink over a period of time. Then this rope that is tying it tightly has now become loose. Similar to that, you can imagine that now the ligaments that were once holding the entire spine tightly have become loose because the discs have actually shortened in height. Because of the sort of disc bulge that is happening, or the reduction in disc height, the ligaments become lax. When the ligaments become lax, the vertebrae have more possibility of moving in directions that they are not supposed to move. And this is typically what happens in spondylolisthesis. It is most common in the L4, L5 and L5S1 areas. Here you are seeing a case where the L4 has moved anteriorly in respect to the L5. So this is an anterior listhesis of L4 over L5. So this is what is happening here. Most common is L5S1, which is 70%, and L4 over L5 happens in about 25% of cases. It can happen in other vertebrae also, but here there is a peculiar thing because of the lordosis that is happening in the lumbar region. This angle of articulation between the two bones is already like this. It is not straight like this. It is like this. So there is a very easy, if the ligaments are not tight, it is very easy for it to slip anteriorly, and that is called as the anterior listhesis that is happening here. See, if it happens very gradually, it may be asymptomatic, but if it happens suddenly, it can cause back pain, severe back pain, but this listhesis itself is responsible for further degeneration and degenerative disc disease and radiculopathy. So this is a condition that we need to be on the lookout for when we are seeing patients with low back pain. So spondylolisthesis is a very important thing. Very often, spondylolisthesis happens as a result of spondylolysis. Here you are able to see that the facet joint, the pars interarticularis is fractured. So this bone has become sort of detached from this bone. Here there is an articular joint, but that joint is actually now separated out. Now the body of the vertebra can easily slip forward. This is a case which is of a very severe spondylolisthesis. It's an illustration, but this shows the degree to which this particular bone has prolapsed from this is used for grading spondyl. I mean, in the previous thing, I didn't tell you that these are graded from grade 1 to 4 based on the level of translation. How much has it moved away? That decides the grade to which spondylolisthesis has happened. So this is greater than grade 2. This is about grade 3 spondylolisthesis. This is a very, very serious condition because the entire spinal cord is almost crushed at this point. See, the spinal canal diameter becomes grossly reduced when there is an anterior listhesis happening by a bone above. So the gap in the spinal canal gets reduced and it can lead to quada equina sort of symptoms, which is a loss of bladder control, loss of bowel control, and so on. The nerves that are coming to the spinal cord are severely impacted here. The same thing can happen also in the neck, and that can lead to sort of paraplegia also, or cervical myelopathy, which can result in foot drop and all those sort of complications. So spondylolisthesis and spondylolysis are some of the complicated things that can happen in a patient suffering from low back pain, about which we need to be aware. The other condition that also causes low back pain is facet joint arthropathy. So as I told you earlier, this is a facet joint where the vertebra above is articulating with the vertebra below. This is typically like a joint. Only thing is it is permitting some range of motion like any other joint, which is why you need a joint. So here it has got the articular surfaces and there is a synovium, there is a capsule, everything else like a synovial joint. And this joint can develop osteoarthritis. So that is why sometimes lumbar spondylosis is also called as osteoarthritis of the spine. So osteoarthritis happening in this bone, or it can happen also in the facetal joint. So in this facetal joint, there is a particular problem because this facetal joint is very, very close to the emerging nerve roots. I'll show you in some other picture how this is very, very close to the bundle of nerves that are coming out from the spinal canal. And thereby osteoarthritis of the facetal joint also can impact or press upon the emerging nerve roots and cause the same conditions as what happens with the disc prolapse. So you can have a serious radiculopathy happening because of disc prolapse as well as because of facetal joint arthropathy. So facet joints are, I told you all this, they lie very close. So the osteophytes from these joints can impinge on the emerging nerve roots. Next, we go to the category. So I think we have dealt with most of the degenerative spine-related conditions, which was the second bracket that we spoke about. Third bracket which we spoke about are the inflammatory systemic conditions that can cause back pain. Among them, the most common one is ankylosing spondylitis, progressive inflammatory condition affecting the spine and sacroiliac joints. So that is one of the things. The primary sort of diagnostic feature is sacroiliitis. The joint between the sacrum and the iliac bones is what is affected, and that gets inflamed. So chronic sacroiliitis is a typical sort of manifestation of ankylosing spondylitis. Of course, there are other things that happen, like ankylosis of all the ligaments that are tying the vertebrae together. So that will result in what is known as the bamboo spine and all that. We will deal with all the minor details of ankylosing spondylitis when we speak about that as a major thing. But with reference to the low back pain condition, we must know that the sacroiliitis is the site of pain that really happens in the case of an ankylosing spondylitis. Here again, we need to understand that there are the two variants, the seropositive and the seronegative. HLA-B27 positive is generally called as seropositive, and if you can even be negative for HLA-B27 but still have ankylosing spondylitis, which is known as seronegative spondyloarthropathy. And that syndrome comprises of many other problems, including psoriatic arthritis, including Sjogren's syndrome, and so on and so forth. There are several other conditions that are associated with this. People can have a triad, including iridocyclitis in the eye, that can be associated with ankylosing spondylitis. Then we also have the infectious spondylitis, as in the case of tuberculous spine, which is otherwise known as the Pott's disease. So even that condition can be a cause of this thing. So these are all not common. It's not like if you see 100 patients, you may hardly encounter even one patient with this, but it can still be there. And we missing that can be very, very embarrassing and also very costly for the patient, and sometimes for us also, because in the coming days, with the increased level of litigation and all that, the vulnerability that we as doctors have. So I think it's very important for us to be aware of these possibilities, and as far as possible rule them out to be not caught on the wrong foot. The other things that also causes low back pain, as we spoke about, are the systemic and referred pain. So pain arising from other structures but referred to as back pain. The pain will be felt here, but it is actually originating in the other structures like the kidney. You can have gynecological issue, which is very common. In fact, endometriosis is a very common cause of low back pain among women. It will generally be more around the menstruation time, and then they will feel some betterment. Most women experience some level of back pain during the couple of days prior to the menstrual cycle, and which gets better once the menstruation starts. So the endometriosis is a very important cause. Then chronic pelvic inflammatory disease can also cause low back pain. Fibroids and all these are. So gynecological conditions can cause low back pain, which we need to be on the lookout for. Abdominal causes like appendicitis. Sometimes the appendix can lie in the posterior portion, and in that case, it can cause. It will not cause the typical pain in the McBurney's point. The pain can be manifested like a low back pain, and in which case it is very easy to get missed. But the other symptoms like feeling nausea and vomiting and all that should raise the suspicion of appendicitis. Even pancreatitis can cause pain, which is sometimes not in the low back. Typically, it will be in the slightly higher back, but back pain can be caused by pancreatitis. And another very important thing that can cause is aorta. The descending aorta at that particular portion, suppose there is an aneurysm and all that, that can also cause low back pain. Very, very rare causes, but something that we need to be aware of, so that we don't land up missing out on some of those complications. And last but not the least is osteoporotic fractures. So this is osteoporosis can be widespread. Spine is a very important site of osteoporosis, and especially in post-menopausal women, it is mandatory to have a bone mass density done once in a while to exclude the possibility of osteoporosis or osteopenia, which can then progress to. I would think that it is very endemic in our country to have low vitamin D, and that can be very often a cause of osteopenia and osteoporosis, especially in inactive people with less physical activity. They are more prone to osteoporotic fractures and stuff like that. So this is something also that we need to be aware of. So here you can see this is how a compression fracture really looks like. The bone has just got crushed. It is not like the fracture in the long bones where it just breaks and then moves away. Here it is just compressed in place, which is why it is called as a compression fracture. And it often doesn't get diagnosed because patients may not experience as much pain as with other factors, but they will have chronic pain. Very rarely, sometimes they may have acute pain, which then becomes chronic, but sometimes they wouldn't have had any sort of acute episode that they can remember, but it would have happened during some jerk or something in an already osteoporotic patient. And then that leads to chronic back pain, which does not respond to general intervention. So this is very, very common in post-menopausal women. In fact, this was one of the main reasons why hormone supplementation was initiated long back. But then, of course, they knew that the drawbacks were much more. This and cardiac risk reduction was the concept based on which they thought about hormone replacement therapy. But that actually was seen to increase the risk of cancer and stuff like that, and that is no more recommended. So we need to be particularly careful about this possibility in post-menopausal women, especially in early menopause, early ovarian failure and stuff like that. This can be a very big issue. Last but not the least, we have the psychosomatic low back pain. We very often very grossly underestimate the possibility of this. In fact, a large number of patients also suffer basically from this. Very, very difficult, a little bit difficult to identify, but there are some clear telltale signs if you are ready to spend the time with the patient, and we do a detailed history taking, as well as we also do some examination. It is very easy to identify psychosomatic low back pain. They will report very, very funny things. Even when you just touch your back, they will say it is extremely painful. So exaggerated expression of pain. Superficial tenderness over the lumbar region to light touch also. Even if there is a severe inflammation, just by touching immediately, there will not be severe tenderness. So if they are reporting extreme tenderness even on light touch, you must have this suspicion. I'm not saying jump into that conclusion, but suspect that very often they may not have a basic, cause for that, but it could be psychosomatic. Non-anatomical tenderness. If there is no region to be, for example, they are saying tenderness in an area where there is no structure that can cause pain. That is a sign of psychosomatic low back pain. Exacerbation of pain by applying a few pounds of pressure with the hands on top of the head. Ask the patient to stand and place your hand on their head and just press it down gently. Ask them if the pain is getting worse. If they are saying that it is getting worse, it is psychological. Because actually a few pounds, you're just pressing your head will not cause any pressure on the disc, and it cannot aggravate the pain. So if a patient is reporting like that, that is a clue to you that it could be psychosomatic pain. So sometimes you can ask them to lie down and get up. They are able to get up. But intolerance to SLR, if you are asking them to do the straight leg raise test, they will say, oh, it is terribly painful. But they can, with no effort, suddenly jump out from a supine position to a sitting position. That's a very important clue that, the symptoms are not synchronous with each other, and that could raise the suspicion of a psycho. I'm not telling that with any one of this you immediately conclude, but along with other corroborative evidence, you must come to that holistic diagnosis as to this possibility. But the most important thing is to bear in mind that this is a possibility, and a very common possibility. People who are chronically depressed have got this tendency to, one of their main manifestations is chronic low back pain, and they can also have chronic neck pain. These two things are very often a cause of chronic depression. These include psychogenic pain and can be due to depression or chronic pain syndrome. There is another thing called chronic pain syndrome. If they are generally not in a happy mood, they are always in a very sad state, or they are not looking at anything positive in life, their pain threshold will increase. They will feel heightened sense of pain with anything that is happening. Even just sitting like this, they will say this is paining, that is paining. So that is called as a chronic pain syndrome, and the pain never goes away. Always 365 days they will be saying there is pain somewhere in the body, very likely to be psychosomatic pain. So this is another very important category. So I have just covered all these things because I think this is the most important thing which can give us that edge in treatment, and certain other factors about our protocols and stuff like that. We'll get into the next slide. So very important thing is in low back pain, what are the red flags or most important considerations? Number one, history of cancer. If it is a patient with a history of cancer, we should not take it lightly, and we must check for any metastasis in the bone or anything of that sort. Unexplained weight loss, again, is pointing towards cancer. So if your patient with low back pain also says he has lost weight, never go ahead with the treatment without checking further. Intravenous drug use, that can be one of the things that is causing a thrombus and a lesion like that, or even the drugs can cause, multiple syphilis and stuff like that. So people who are used to, intravenous drug use very often get the communicable diseases, especially including syphilis, which can be one of the infective causes of low back pain. Prolonged use of corticosteroids, Obviously, we know it causes osteoporosis and that can lead to compression fractures and so on. So while history taking, if we see all these particular things manifesting, we should not casually go ahead with just treating the patient without arriving at a clear diagnosis. My perception is wherever possible and affordable, it is important to arrive at a clear diagnosis before we intervene. Other than in very small acute cases in the first week or so, up to a month or so, it is okay. Older patients, major trauma, osteoporosis, fever, back pain at rest or at night, bowel or bladder dysfunction. So if these are some of the symptoms that should raise a red flag in your mind, immediately become cautious and investigate further so that we don't land up in trouble. This could mean serious underlying conditions like cauda equina syndrome, like bladder and bowel incontinence is a typical sign of cauda equina syndrome. Malignancy and spinal tumors. Vertebral fractures can happen due to osteoporosis, but they will say, I never had any injury, I never fell down or anything. But if you take an MRI or an X-ray, you will see a pakka compressed disc. A compression fracture not a disc, I'm saying compression fracture of the vertebra. You can have spinal infections or epidural abscesses. Vascular compromise. So blood vessel getting blocked and that can cause AVN and stuff like that. Not very common with the spine, but yeah, even that possibility is there. So these are some of the red flags which we must bear in mind and eliminate when we are, examining a patient with low back pain. I hope this thing helps. We will be sharing this detail with you. As I said, keep it as a ready reckoner just in case, we don't forget it out anytime. Now we'll get into the therapeutic concept. Having understood this, I would like to suggest, first I'm giving a general conceptual thing of what we do in different sort of situations. In muscular strain and sprain, the concept is primarily it is a self-limiting condition. We just need to give rest for that particular region till it recovers. We can do some small intervention in terms of some oil application, mild massages, etc. No powerful massage, but very mild massages. Sometimes even without that, it will respond. In our experience, very, very few patients actually come to us in this stage. Basically, they go to allopathic doctors or take a painkiller. That's the culture in our part of the country. People go to a medical shop and take a painkiller. If nothing works, only then they consider coming to a doctor. So we don't get too many cases of this, but it is very prevalent. The next is the referred pain. If the patient is actually suffering from back pain, but actually the problem is referred from other disease, common sense dictates that the treatment is only for the underlying cause. We don't have to be treating back pain. But this we can do only if we arrive at a pakka diagnosis. That's why the importance of diagnosis upfront. Otherwise, we will be just giving them treatment. And much later, the pain is not coming down. They go to another doctor. And that doctor does a primary investigation. And he finds that after all, the issue was endometriosis. Then we will look like fools not having diagnosed that. So it's very important for us to exclude that potential of being embarrassed. In degenerative conditions, of course, the conceptual thing is to do anti-degenerative intervention. Is in our case, Vadahara Snehas, specifically Asti Poshaka Snehas are the mainstream therapy there. Bahya Abhyandara Sneha is what Ayurveda talks about for this sort of condition, and Vasti Karma. So these are the most important treatments mentioned in our classics for degenerative bone-related problems. So that's a very straightforward understanding. And in associated inflammations, we all know the role of Gugulu Kalpanas and Amahara, Vata Shonita Hara, Kvata Yogas. So that is the concept of treatment there. So Amahara, Vata Shonita, Amavata Hara is the concept of treatment that we do here. Then when we go to this, we also have Ruksha Lepana, Ruksha Svedana, Lepana, etc. So Rukshata is the initial phase of treatment, both Abhyantara as well as internally. Rukshana is the first element of treatment when we talk about inflammatory conditions, not only in the back but also elsewhere. So Rukshana, like the sutras, Chikilsa Sutra says, Nite Niramatam Swame, Sweda Lengthana Pajanehi, Rukshaischa Alepa Sekadyehi Kuryat Kevalavadajit. So before you do a Kevalavada Chikitsa for the degenerative disease, if there is an AMA association, first do the Ruksha Prayogas, make it into a Nirama condition, and then do the Kevalavadika Chikitsa. So that concept applies everywhere. Even here, the same thing applies. But the thing is, very often, there are cases, very often when they come to us, it is already very chronic there may not be any AMA association in many patients. So you can straight away go in for degenerative condition, anti-degenerative treatment. Again, it is slightly region specific. In Anupadesha, for example, very often the concept of AMA should be a little bit more carefully dealt into, whereas a Jangala Desha like ours, in a very Ruksha Desha, the role of mild AMA will not aggravate the problem. Anti-degenerative treatment may be initiated upfront itself. I found a difference in treatment when we treat patients in Kerala as well as people in Tamil Nadu. There is a difference in the desha that has an impact on their bodies and the way in which the body responds to the treatments. In non-organic causes, that is, there is no condition, there is no diagnosis, there is no problem. The spine looks great, MRI is great, but patient is suffering very badly. As I said, in the psychosomatic cases, counseling therapy, psychosocial approaches, cognitive behavioral therapy, psychotropic medication. So these are all the conceptual approaches. So I think, nutshell, if you talk about the Chikitsa Sutra, it is all here. Now we will go into the detail. Like Ashtanga Hridaya mentions, initially Chikitsa Sutra is given, and then we are given the detailed explanation. I am following that model here. So now I am going to explain what our clinical pathway of how do we go about with a patient suffering from low back pain. The first step is to look whether there is already a clear diagnosis. Fortunately for us, most of the patients who come to us already come with a whole bunch of center. So that benefit is there. But earlier, in earlier days, we never had that sort of thing. People with all different stages used to come. So the first thing that we look into is whether there is already a clear diagnosis. And sometimes you can have some diagnosis which doesn't match with the clinical findings. That also happens. Let me warn you, but it doesn't mean that an orthopedician seeing them always sees all the things. We should still not take it for granted. We must do the due diligence on our side. We have treated cases where there was a foot drop in a patient who came here, and they took an MRI of the lumbar spine and found there is lumbar spondylosis, and they did a surgery for the spine. Nothing happened. The foot drop continued. The patient came here. We just did some reflex, deep tendon reflexes when we tested. It was briskly positive. Then immediately we suspected this is not a lower motor neuron lesion, it's an upper motor neuron lesion. And then when we look at the spine of the brain and this thing, we found a very solid disc prolapse in the cervical region, which was actually causing this. We treated them for chronic cervical spondylosis, and the patient's foot drop recovered. So I'm just telling you, just because a big hospital, an orthopedician have evaluated them, they have done MRI, but that was the wrong thing. But when they did an MRI, they found some lumbar spondylosis, which is always evident. Most people above the age of 45 will have some level of spondylosis. So very often it need not correlate with your clinical manifestation. So you need to sort of give importance to both the clinical manifestation as well as the objective diagnostic radiological findings and blood workup if needed. And putting all this together and using our history, case history as a very important clue. So a synthesis of all this is what will really help us to arrive at a very precise diagnosis. And in my opinion, that is what really will distinguish us from the majority of, everybody who is just, capable of giving a medicine. So first is to look for a clear diagnosis. Then look for signs of inflammation. So he has got lumbar spondylosis, is very clear. But generally, typically, even an orthopedician might not have looked at signs for inflammation. They immediately, look at spondylosis and they will give some painkiller. But we will have to look for signs of inflammation or AMA. And if there is an AMA association that we are able to identify even through our clinical findings, then immediately be on the side of caution and look and treat for AMA. If diagnosis is not clear, or if diagnostic protocol is not complete, additional tests are advised along with the initial OP treatment protocol. We often don't send that patient away with no intervention. They expect to have some intervention. So we will start with an initial OP treatment protocol, but also advise them to undergo some tests and come for a review very quickly. The initial treatment protocol is based on these two factors. That is, if we find based on the severity of symptoms, the chronicity of the condition and the impact of the disease on their day-to-day functioning, then we first decide whether they can be managed at the OP level, whether they need to undergo some sort of a daycare therapy, or whether they will need inpatient treatment. From our experience, a very small percentage of patients actually need inpatient treatment. Only when they have got very, very severe severe disc prolapse leading to radiculopathy, and they have been undergoing treatment for a long time, and surgery has been mentioned as the only option, and so on and so forth. In fact, it is that small segment of people where we are actually subjecting them to inpatient treatment. And we are able to avoid surgery in all those cases. If we are able to identify what exactly is the condition and admit them, we are able to avoid surgical intervention in all those cases. A very small percentage of them actually need inpatient treatment. Most of them can very wonderfully be treated through the OP treatment protocol. So this is the first thing that we do when we see a patient with low back pain. So then I will describe what we used to do for a long time. The traditional treatment approach, which was there earlier, was in mild cases, that continues to be even today. We just ask them to apply some Dhanvantaram Thailam and Karpura Thailam mixed together, wait for about 45 minutes and wash with warm water. Yes, doctor, I think when you're raising hands, we will answer all that at the end of the presentation. You can raise it as questions, or later we can even have one-on-ones. Yeah. So we can ask them to take rest for a couple of days and then start mild stretches. It's earlier, the treatment protocol that used to be recommended was complete bed rest. I'm saying even for severe lumbar disc related problems, earlier people used to be advised to be at total rest for a month or so, which is a very disastrous treatment protocol. It has already been thoroughly sort of dismissed. Now it is not recommended at all in modern medicine. The reason is when you are completely immobile for a long period of time, you lose muscle tone, which is counterproductive. So you shouldn't actually ask any patient to be at bed rest for a very, very long period of time. So for a few days, yes, a little bit of rest is fine, but then slowly they must get into mild stretches, very, very mild stretch, and then slowly when it becomes lesser. So this is all that is actually required, but you can also give them some internal medicine which speeds up that healing, and also for a psychological effect also you can give something. Moderate to severe cases, there we can add Trayodashanga Guglu DS 2 tablets twice a day, or painflavin tablets 2 numbers twice a day. We used to give that for patients who definitely thought they wanted a medicine and all that. So traditional treatment used to look like this for a muscular, sort of an acute muscular back pain. Our traditional treatment protocol, the chunk of patients that we get is not for a mild muscular pain. What we get is for severe non-muscular but degenerative sort of thing, which will fall into these two brackets. One is chronic patients with no ama, and chronic patients or patients with ama or inflammation. So let us categorize them into two categories. What we used to do earlier was to give them kashaya yogas like Sahajaradi Kashayam along with Sahajaradi Avartita. Then Dhanvantaram 101, Gandha Thailam, etc. Dhanvantaram Thailam. So as the concept holds, Snigdha Brahmana Chikitsa used to be the mainstream here for these chronic patients with absolutely no signs of ama. And if the pain is severe, we will again add Trayodashanga Gugulu. Additionally, if the pain is really severe, we might also recommend them to undergo Patra Bodhali Sweta, etc. Or very severe, then we ask them to come here to undergo Kadi Vasti and so on. Thailadhara or Pirichil also after a few days. If the pain is very severe, this is what we used to recommend. But this is a small percentage of patients, as I said earlier, who need these therapies. Actually, home-based therapy and medication itself will give very good results in most of these patients. This is how we used to manage. Whereas patients with ama, what we used to give them was Rasna Saptakam Kashayam, Trayodashanga Gugulu, etc. Dashamola Hedidigi used to be given. Then we would give them Arthurab liniment only. We wouldn't give them the Dhanvantaram Thailam or such Brahmana oils, just something which can give them some pain relief, and a lepam of Rasnadi lepam and so on. I'll describe these in more detail. There are many options in all this, which I'll describe, but I'm just giving you the feel of what we used to do. If there is fever or feverishness, we would add Amrudayarishtam with Gorojanadi, etc. If fever is severe, but there is, if the pain is severe, but there is no fever, we can do Dhanyamla Dhara, Churna Pinda Sweda, Madhu Dailiga Vasti, etc. So these are also things that you can do. Actually, Dhanyamla Dhara you can perform even in patients if they have fever. We don't have to worry. We are doing that. But as I said, this therapy is only in very rare cases. Most of the patients we can deal with only with the medicines and these sort of home-based therapies which they can self-administer. So this used to be our regular way of treating earlier. But while we were analyzing, we found that many patients would experience significant improvement, but what they would not continue treatment. This was the main thing that we observed. They will take this kashayam and all that when the pain is very severe, and after that they would not continue to take the treatment. Then they will not. Then after some time they would again get the problem. So they will not continue to take the medicine due to the difficulty of taking the medicine. This is a very important finding that we found. So while problems used to subside, they would get frequent relapses. They were very hesitant to continue to take the medicine because of the difficulty associated and the taste and all these factors. People with travel requirements and those very sensitive to taste, office goers, were having much lesser compliance. So they would not continue. There was clearly a need for more convenient and more effective solution as well. After the success of Servilon, see, by that time we had come out with Servilon as the first product, as a Thyla in soft gel, and that had really become a huge success. We were sure that a convenient dosage form with high efficacy was the need of the hour, and that would transform patient care, compliance, and reach. So the formula was already clear to us that if we make it a very, very effective product in a convenient dosage form, people will use it better, and that will give them better results. And that is what really gave rise to our invention of this group, the Lumbaton group of products. The Lumbaton capsules we created, which is basically for the Snigdhala. That is for the degenerative condition, is the Lumbaton capsule, anti-degenerative healing formula with potentiated medicated oil. We also had Lumbaton tablet as the anti-inflammatory tablet with high efficacy and convenience. So that was our tablet solution. So we originally launched these two products, Lumbaton capsule and Lumbaton tablets. And that is how it was going on. But over a period of time, what we found out was that most patients were actually being given both. That is when we discovered that it is then, to make it even more convenient, we thought one product which has both the components will be very, very effective. And based on that clinical insight is how we came out with Lumbaton plus soft gelatins, which is a combination of Lumbaton capsule and Lumbaton tablets. I hope the distinction is very clear. So the Ruksha Prayoga is the tablet, the Snigdha Prayoga is the capsule, and the Amahara and anti-degenerative club together is the Lumbaton plus soft gel. So what are these products? I'm sure you have all been exposed to that. I'll just touch some of the points. I'm sure our medical team is also briefing you about all this. If not, also we'll share more detailed information. I will not go through all the details. Suffice to say that primarily it is derived again from the Sahajaradi Yoga. Only thing is we have also added an additional element of Eranda Thaila for Apana Anulomana in this combination. So Sahajaradi Avartita is the sort of base for this, and we have fine-tuned or tweaked the product to some extent based on our other combinations that we used to use. That is how Lumbaton capsules came to be. So again, the dosages, features and all that I will skip for want of time. Then comes the Lumbaton tablets, as I told you, which primarily has the elements of Rasna, Saptaga, Sahajara Kashayam and Gugulu. So Gugulu, the Rasna, Saptagam and Sahajaradi combination, you can imagine that is actually, that will give you an idea of what you can expect from Lumbaton tablets. And that is how the Lumbaton tablet is designed. And we have the Lumbaton plus soft gelatin capsules, which are just the combination of these two. So one element taking care of the inflammatory potential, the other element taking care of the anti-degenerative potential. The higher element in this is the anti-degenerative. The capsule is the larger percentage in this, and the tablet is a smaller percentage in this combination. So this has now revolutionized our whole treatment and the compliance to our treatment. That is where the big change has happened. And of course, we do adopt these external therapies such as Abhyanga, Piju, Kadivasti, all this is done. So Bahya Abhyantara Sneha, as the Abhyantara Sneha, we give them Lumbaton plus, and as the Bahya Sneha, we use all these oils, Dhanvantaram, Thailam, especially it is very effective for strengthening and for injury. Sahajaradi Thailam is renowned for its effect on stiffness, and it can very well be combined with Dhanvantaram for a patient who has both pain as well as stiffness. Murivanna is used in acute injury, in a Pitta Pradhana condition, and where there is Shobha, etc. Especially when you see a Pitta Anubandha and Shobha, then adding Murivanna becomes a very good thing. So also in acute injury. This can be combined with Dhanvantaram Thailam also. Our treatment is the mainstay is Dhanvantaram Thailam. We add these to that. Prabhanjana Vimardhanam Kodamba is also another thing that we use for pain relief. It is a little bit more Ushna property oil. Then we have Mahanarayana Tailam, or what we call as Narayana Tailam Big. This is used for people with the neuropathy, associated neuropathy. This is also slightly Sitavirya oil. So this is how the oils are there and how we use it in different situations. I will share all this with you as well. So we will go through the slides at a slightly rapid pace. Then as external lepana, Churna Binda Sweda, etc., we use Rasnadi Lepa, which is a moderate Virya. It is neither too hot nor too cold. It is slightly on the Ushna Virya side, but not very Ushna. Kotanjukadi Lepam is Ushna Virya Lepa, which can be used. Very good for edema and pain for Vata Kapha predominant condition, where there is no, and the thickness of the Lepa has to be moderate only. In a Rasnadi Lepa, you can use a warm and used as a thick layer. Jatamayadi Lepa is a Sida Virya Lepa Churna for relieving edema with Pitta Anubandha. So use it as a thin lepa. Kola Gulathadi Churnam is the Churnam of choice. You can use any of this also, but Kola Gulathadi is most commonly used for Churna Vinda Sweda that we advise patients to do. We actually create this one portly and give it to our patients and ask them to use it at home. We also, at the hospital level externally, important tool in reducing ama in systemic inflammations. Even in the presence of Jwara, it can be used. Avagaha is another very important external procedure which is useful for, we use multiple combinations. We can sometimes use highly diluted Dhanyamla, Deshamula Kwatha with Eranda and Nirgundi Patra, the Deshamula Karaskara Kwatha itself. So you can prepare your own combinations of Vatahara Patra Kwathas and prepare Avagaha tub and make the patient sit in that warm Avagaha tub. It really improves stiffness, it improves the relieves pain, and it's very good for chronic inflammatory back pain. Our OP protocol treatment, now for each of this, I will tell you post lumbar tone. So prior to lumbar tone, as I said, we were using multiple things. So post lumbar tone, our protocol has become much simpler. In most cases, other than sacroiliitis, rheumatoid arthritis, seronegative arthropathies, we start the treatment by giving patients Lumbaton plus capsule, 2 numbers thrice a day after food. Just that for internal use. Dhanvantaram Thailam plus Arthurab liniment for external application. We have actually come out with a new spray called Elevate Back Care Oil Spray, which is very convenient to use. Anytime they can just spray it, smear it and go to bed. So especially when there is an immediate pain relief required, you can use the spray and at night. So this is what we recommend for most cases now. And gradual back stretches starting with Pavana Muktasana. If there is no severe pain, the patient is able to tolerate it. One of the most effective things to relieve the stiffness and pain in the short term is Pavana Muktasana. Don't overdo that. Let them do it to the extent they are able to comfortably do. This is a very, very effective thing to give them a relief. So I generally advise my patients to do it twice a day, once in the morning and once in the evening. As soon as they get up in the bed, let them perform the Pavana Muktasana and then get up from bed. They will have much less discomfort because maximum pain is more in the morning when they get up. Now so this has been the mainstay. Now, if you look at our treatment, it is centered around this piece now. So this has become the pillar of the treatment. Now around that, we keep modifying, we keep doing the personalization and individualization of the treatment protocols. Now, if you take the case of postural and muscular low back pain, Lumbaton plus 2 numbers is what we get if it is acute. Twice daily, more than enough. Dhanvantaram Thailam, Arthurab and Elevate spray. This is all that we give them. And we ask them to take rest for a few days. If chronic, it can also be postural chronic pain. Then the Lumbaton capsule thrice a day will quickly help them get over the pain. Then it can be changed to Lumbaton capsule alone. Only in the initial phase, you need to give Lumbaton this one. Then it can be reduced to 2 numbers twice a day, depending on how severe the affected disc. Sorry. Dhanvantaram, Thailam, Arthurab, all that remains the same. Advise regular back stretching. Pavana Muktasana twice a day, 20 reps for each leg, hold for 20 seconds each time. When pain is fully cleared, only after the pain is fully cleared, we recommend patients to start slowly with core strengthening exercises. The plank exercise is very effective for as long as they can hold it. Slowly ask them, ideally go up to 2 minutes, up to 3 times. So that is the real high end. Most patients can't do it. They will start with say 10 seconds, 15 seconds, but it's fine. Ask them to keep doing slowly, that duration will keep increasing. And this protocol will help them become very, very, strong and prevent recurrence of the disease. They can continue to take Lumbaton at a small dose, even once a day, of 2 capsules. If they got no symptom, even as a preventive, we recommend that as a small dose. For acute lumbar strain, again, we give only this. Rest for a couple of days is very important. This is followed by light activity. That is the main difference in this particular thing. Otherwise, the treatment protocol remains the same. That is Lumbaton 2 numbers, twice or thrice, depending on the severity. Dhanantaram Thailam Arthurab, Elevate and Rasnadi Lepa. This is the main thing: lumbar spondylosis and disc prolapse and sciatica. So all these different things. At the OP level, what we do is, if it is mild, again, only Lumbaton, Dhanantaram, same thing. The other thing additionally that we advise is, while sleeping down on this, ask them to sleep on the side with their knees bent and with a pillow between the knees. Or if they are flat, if they are asked to lie down flat, they need to keep pillows below the knee so that the hip is slightly flexed. This will relax them and they will feel much more comfortable. They will be better off when they are waking up in the morning. Normally, the back pain will aggravate when they get in the morning because the blood flow becomes less, the stiffness increases. So this is something very effective for that. Moderate and then morning, as soon as they get up, let them perform Pavanamuktasana and then get out from the bed. Moderate and non-acute conditions, Lumbaton, the dose is increased to thrice a day. And the same thing continues. If it is a little bit more severe, we can ask them to do some Kati Pichu with the suitable oil at home itself. In acute exacerbation, we also add Zeotone plus capsules, 2 numbers, twice a day. If there is severe aggravation in pain, they are normally doing well, but suddenly they did some heavy traveling or something happened and they get some extra pain, then only Zeotone plus we are adding to that. Because that has got the highest level of Gukulu and it can give an immediate anti-inflammatory effect. So at a much faster rate, Zeotone plus is very, very good at doing that. So that is when we add it at an acute phase of pain aggravation. Severe pain. Patient with extremely severe pain, we advise the same protocol only, and we also add Churna Pinda Sweda once in a day. We give it to them at home and ask them to do that. Always make it a point to test for vitamin D levels and advise supplementation. In all these conditions, one of the very important things I do is to ensure that vitamin D is checked and corrected. If refractory to treatment with the above protocol. So this is the protocol we do for even the severe patients with severe pain. If the treatment is not, if they are refractory to the treatment, it is not improving, or the pain is so bad that they are not able to carry on with their normal activity. They have to go for work or they have to do other things and they can't wait. They cannot wait for 1 or 2 months for their pain to become normal and they are in a hurry to get better. Then we recommend them to either undergo daycare therapies or get admitted and undergo IP treatment. So what do we do when we do this daycare therapy or inpatient treatment? The medicines are same as the above. Only thing is, additionally, we look at their entire health profile. We do a detailed blood test and everything, identify all the possible additional complications they have and address them holistically. For example, if they are diabetic, we tablets. If they are having acidity or something like that, we add pulsarate tablets so that even with the gugulus and all that, they don't get any problem. This applies to the OP as well. If they are stressed, very important for us, we also look at their stress level and add permanent capsules. If there is osteopenia or osteoporosis, we add Zeotone plus capsules. If they have temporarily also, they can have some raised ESR and CRP. It is something we make it a point for every patient we admit, we look at these things. If they got high ESR or CRP, we administer them the Amahara, combination of Rasna Saptagam and Amavadhari KT. If they have fever, we give them Amrita Aristam Gorojanadi. Very rare it happens, but if they get even fever due to some other throat infection or something, that will interfere with the treatment. So we ensure that it is immediately corrected. If they are constipated, we give them Ganga and Lehium, 10 grams, so on and so forth. I don't generally use Eranda Thailam too much here, though Eranda Thailam is considered excellent here, because patients experience a lot of abdominal discomfort and this thing with the use of Eranda Thailam. People, I'm not a big fan of using Eranda Thailam unless it is absolutely unavoidable. I use Mishra Sneham, even there, the same condition is there. They will have severe cramping in the abdomen before they have bowel movements. But if nothing else works, that is the panacea. Ultimately, Mishra Sneham is the wonderful solution for chronic constipation that does not respond to anything else. But I don't start with that. I give them Ganga and Lekyam, which itself solves the problem in most cases. Then what are the therapies that we do during the IP or daycare? We start with Abhyanga and Churna Vinda Sweda for 5 to 7 days. And also Sarvanga Sweda is done after that. And we give them Madhudailika Vasti on day 3, 5 and 7 with Sneha Vasti after lunch. So morning after the therapy, they are given the enemas, the Kashaya Vasti, and then post lunch, they are given Sneha Vasti. We give them Abhyanga with Patra Potala Sweda with Kadi Vasti then for about 7 days again. Then, for that, then we also give them Shiravasti on alternate days. Shiravasti, many combinations can be done. The most common is Sahajaradi Kshiravagam with Sahajaradi Medubagam, Sugumara Gridam, honey and Chadapushpa. So this combination, as per the classical protocol of Shiravasti, Kshira Dvo Prasardo Karyo Madhu Taila Gridas Traya. So that is the formula that we use. That is 2 Prasada of 200 ml of this one. 200 ml, 100, 100, 100. So totally 500 ml will come. So this is what we do for Kshiravasti. If very chronic and patient is willing, then we also give them 5 days of Thailadhara with Kanyamala Thailam. That's a very, very effective thing for, for long-term this thing. But if the pain will all be fine by this time itself, they will be feeling perfectly okay. But if they are really interested in the long-term benefit, we also recommend Thailadhara for 5 days. Physiotherapy is done throughout this thing. Physiotherapy initially for pain relief, followed by flexion exercises, and then gradually entire range of movements for flexibility, and finally strengthening the core muscles. So this is a sequential intervention through physiotherapy that we have sort of standardized, and this along with the treatment gives them phenomenal results. 10 to 11 days, that's all. And by then, most patients are fantastic. 15 days max for a very severe lumbar spondylosis patients, including Thailadhara. That is the duration that is on an average. This is very crucial for long-term preservation of recurrence, which means this exercise, asking them to continue the exercise and some medication as Numberton alone, Numberton plus alone is more than enough as a continual treatment. This is what we do for our very severe degenerative arthritis patients, degenerative lumbar spondylosis patients. Facet arthropathy, like I said earlier, is like osteoarthritis of the spine. And so we treat it as the same protocol as lumbar spondylosis. Only thing is we add zeotone plus to prevent the degeneration of the bone from furthering, and it also reduces the inflammation. If there is severe inflammation in the short term, then we also add painflavan or zeotone tablets, 2 numbers twice a day for a short period. If ESR and CRP are elevated, which is rare, if it is elevated, we can also add Rasna Saptagam and Amavatari Kashayams to that, as Kashayams or tablets. For spondylolisthesis, again, treatment is the same. Spondylolisthesis with or without spondylosis is the same. The main difference, if it is greater than grade 2, they should be referred for surgery. Very dangerous to go on without surgical correction for a grade 2 spondylolisthesis. But for grade 1 and 2, we can very beautifully handle that condition with our treatment. The treatment protocol is the same. Only thing is, most important point is completely avoid extension exercises and even prolonged standing till the core muscles are strong. So if the patient has got to stand, they must definitely wear a lumbosacral belt. And teaching them how to maintain the posture is very important. Along with that, weight management is also very critical in spondylolisthesis patient. For every back pain, it is good, but more so for a spondylolisthesis patient, because a person with a protruded abdomen stands in a hyperextended pose. The extension is always there. They push their abdomen forward and stand, which aggravates the spondylolisthesis, the pressure on the ligaments. So very important for them to, for us to advise their posture correction, as well as to help them to lose weight and lose abdominal fat. So this is the main consideration that we have to have with respect to spondylolisthesis and lysis. Lysis does not heal with our treatment. Even I've seen, I'm actually a patient who has got lumbar spondylosis, spondylolisthesis, disc problem and all that. I developed that about 30 years back, but there is nothing that I don't do. I climb mountains, I carry weights, I go to the gym, I'm able to do everything. now, and I think I am able to do with no hesitation about anything in life, because we know the concept, and if we can manage it, it is perfectly fine. Then comes the inflammatory arthritis, ankylosing spondylitis, rheumatoid arthritis, and psoriatic arthritis. That is typically to be dealt with as a separate topic because it's such a comprehensive thing. But as a sutra, as I said, main thing is, use the Amahara combinations like Rasana, Saptaka, etc. Tablets like zeotone and painflavin, Amapachana, Vadarakthahara, medicines like Amavadari, Rasana, Saptakam, etc. They are very, very effective in reducing inflammation markers. The daycare and IP protocols will be more or less similar to rheumatoid arthritis treatment protocol with predominantly Ruksha Svedas including Dhanyamladhara and Yogavasti, which is indicated. Once the inflammatory markers are well, any Snigdha Prayoga in a patient with this condition should be only after the inflammatory markers are totally under control and there is no sign of ama left in the patient. This is very, very important. If you use a Sneha Prayoga earlier, you can see aggravation in the condition. Osteoporosis and compression fractures. In addition to the normal treatment protocol for degenerative spondylosis, zeotone plus capsule at a dose of 2 capsules thrice a day is very effective in speeding up recovery and relieving pain. Generally, it takes a couple of months for them to become better, but this one will make it faster. Patients have advised rest for a period of 30 to 45 days. Rest, matlab, not total bed rest. They have to do some essential movements, but ensure that they're not standing for a long time, not sitting for a long time. They have to keep changing their position frequently, but not do anything strenuous. And they must wear lumbosacral belt also. Lady patients would benefit by adding Gynaven tablets 2 numbers twice a day. We have found that Gynaven tablets acts very positively in these patients and helps them improve both osteoarthritis as well as osteoporosis. Gynaven as an additional intervention is very safe and effective for postmenopausal women. And local Piju with Dhanvantaram Thailam plus Morivarna is also very effective. Practically, it's a little difficult, but if they are homebound and they are in bed rest, I think this is one of the very good things to do. But sometimes they'll find it inconvenient because at home to do all that may be difficult. Yeah. Referred low back pain, as I said earlier, we only have to treat the basic condition. We should not treat it like, back pain. We may get some benefit with renal calculus with our lumbar spondylosis treatment because apana anulomana, they can get some pain relief and all that. The spasm that is happening might come down, but that does not completely solve the problem. So our treatment approach should be to address the root cause rather than try to consider it as a back pain and give the same treatment for back pain. Last but not the least, the psychosomatic back pain. In the absence of all other issues and in patients with depression and chronic stress, low back pain is common, as I said. Though therapies like Abhyanga, etc., may give some temporary relief, Shirodhara, all that we can do, they need to be appropriately diagnosed, monitored, and treated. Of course, the diagnosis is the most important thing here. Then we can, along with the other things, we can also do our therapies, which can be also improving their psychological state. But the diagnosis is the most important thing. But for patients with clinical depression, we'll have to categorize them into people who have really clinical depression or they have only got subclinical depression. I think it's very critical to distinguish between the two. And if there is clinical depression, my personal preference will be that they should be advised to undergo psychiatric intervention with antidepressant medication as well, or under an expert, Manasika Roga Vidagdha in Ayurveda, the access to which is not very prominent in all places. I'm not sure about how it works out practically, but I'm sure a very professional intervention is important for a patient with clinical depression because it's very likely that they will have suicidal tendencies. So it's very important not to neglect that, and professional counseling and appropriate treatment is needed for treatment procedures for pain relief. In addition to, along with the treatment procedure for pain relief, we should definitely ensure they are undergoing something like that parallelly. Cognitive behavioral therapy is one of the most important tools for long-term relief from clinical depression. So if you have access to that, it will be good for you to advise your patients to undergo this. I find that in many cases, even psychiatrists don't prescribe this. They don't ask them to undergo because they are not available everywhere, but now online cognitive behavioral therapies are available. So it will be good for us to recommend them to undergo treatment by a cognitive behavioral therapist if they are suffering from depression. It will be a great service that we do to them, and that can help them get over depression forever. Whereas those with subclinical depression, they are not very enthusiastic, they are slightly down and all that, we can treat them very well. Permanent capsules are very effective in treating those sort of conditions. Kalyanakam Kashayam tablets, Mahakalyanaka Gridam, Ashwagandha Arishtam, Saraswata Arishtam. So we have all the Medhya Rasayanas and several products in our category, which can be very effective in dealing with subclinical depression. But for clinical depression, just an OP treatment with these medicines is not enough in my personal opinion. External home-based therapies, we can also advise them to do Abhyanga at home. We can give them these liniments and sprays to use at home for temporary pain relief. We can give them the Churna Binda Sweda to be used at home. We can advise them to use the Lepa, Pichu, etc. at home. So these are supportive treatments that we can recommend to patients, and they can carry it out at home as well. Exercises for back pain. There are several exercises. It's a very integral part of living life free from back pain. Because otherwise, once back pain, you are always a back pain patient if you are not really going to do exercise and strengthen your core muscles. So ultimate long-term solution is all our treatments will be supportive and they will relieve the pain, but to not get pain again, the ultimate solution is core muscle strength. So any treatment protocol has to include exercises appropriate to the stage of recovery and ultimately culminate in core strengthening exercises to keep one free from back pain. Specific exercises are recommended for different conditions and should be recommended with full understanding of the cause and stage of the disease. I shall share a document with details of exercises for different conditions with links to videos on how to do them later. So, at the end of this, we are going to be sharing a form with you as to, what are the types of resources or what sort of supports you would like to receive from us, and based on which we will be happy to share those resources to the best of our ability. To summarize, a majority of cases of back pain will respond to a uniform protocol using Lumbar back plus as the Lumbar plus capsules as the pillar. Major differentiation in therapeutic protocol is between inflammatory, degenerative causes and referred pain from organs. Exact diagnosis using modern diagnostic methods enables fine-tuning treatment approach and better outcomes. Precise diagnosis will prevent embarrassment in case of patients subsequently visiting other specialists. And it also aids more precise understanding of the pathology, enabling innovative therapeutic innovations. So with this, I come to the end of my session. And as I said earlier, we are happy to support you in your clinical success. We are ready to share you the ready-to-use protocols. We can have case discussions later based on your interest. We can have more case discussions. We are ready to share you outcome measures. How do you really see whether the patient's improvement? How can you measure it in an objective manner? There are internationally approved outcome measures available. For those of you who are interested, we are happy to share that resource with you. We are actually observing that in our patients. We have got thousands and thousands patients records of what they were before and after and how they have improved in terms of their outcomes using things like Roland Morris score. So that is an international questionnaire based on which we can evaluate the condition of the patient before and after treatment. Then also we are happy to announce that we have a referral program where doctors who are only having an outpatient facility and do not have access to a dependable Ayurvedic hospital, we are happy to collaborate with you and take care of your patients and give them back to you with all the details so that you can continue to take care of them, and we can work in a collaborative manner, and we are happy to support you in that area as well. So those of you who are interested in any of these resources or supports from our side, please feel free. We are going to share a sort of a questionnaire as well at the end of this, and let's take this process forward, because there's so much of people who are suffering from this unnecessarily, and we should be able to make a difference. Thank you. Now I would give it over to Dr. Dilip. He wants to share some information, and then we can have our questions and answers.
Thank you.
Sorry for the time again. I've overshot my duration very badly, but I hope it was helpful.
Thank you so much, Dr. Ramesh. I hope my screen is visible to all of you. So
Not
if
yet.
any of, oh, is it? Okay, 1 minute. Dr. Ramesh, if you could just stop sharing your screen, it would be great.
Yeah.
Yeah.
The QR code is only half visible.
Okay, I'm just opening it up. Yeah, so I'd like to say if anyone is interested in availing any service from us, any extra support with us, please do scan this QR code. You will be requested to fill in a form. Please do fill in that form. It is very simple. It just asks you what are all the supports that you require from us with respect to treating low back pain. And also for all the people who have attended live, we would like to thank you. And we are offering a special introductory offer for Lumbertone Plus, wherein you'll be able to get Lumbertone Plus with a 3+1 offer and at a 30% discount from MRP. So all those details are available. I would request you to please scan the QR code and select all the services you would require, and we shall respond to you accordingly. I'm just displaying the QR code for a couple of minutes. While that is there, there are a few questions that have been asked, and I would be asking that with Dr. Ramesh so that you can get it cleared. Yeah. So one question was, it was from Dr. Archana Muralidharan. The question is, how to manage patients with multiple hemangioma of vertebrae? Patients having
Multiple hemangioma?
Yeah, multiple hemangioma of vertebrae.
Actually, I don't have a practical experience of having managed that. But very often there are small hemangiomas which are non-consequential. That need not be, unless it is they have got aneurysms or some genetic disorder which is predisposing them to that. I think I've not really really treated any patient to be able to share meaningful insights. I'll just have to make a guess about what could be effective on the fly. So practically, I'm sorry, I'm not able to help you there on that particular front. Yeah.
Thank you so much, Dr. Ramesh. So the next question was from Dr. Kapil. If patient is suffering from severe pain, then at present, some effective Ayurvedic painkiller or spray required to relieve immediate pain. Is there any? So his question is, if patient is suffering from severe pain, is there something that they can administer to relieve pain immediately?
From my experience, we don't have typical analgesics. I mean, like an allopathic medicine, I mean, like an indomethacin, there are so many aceclofenac or, whatever, which will give you relief from pain in about half an hour to 45 minutes. That level of powerful analgesic effect I have not seen from our medicines. But, the external spray, then our Elevate oil is really able to give a sort of a temporary relief in a mild to moderate pain. Muscular pain especially, it will relieve. We don't have typical painkillers so for acute use, but what I have seen is their necessity to take this will not be there. Maybe 1 or 2 days they may need to take an aceclofenac, but once they are on this Lumbertone protocol and the protocol that we are recommending, they will not have to keep taking the painkiller. So what we do here also is in that acute phase in our hospital, if a patient is suffering from severe pain, we ask them to take the painkiller for a day or two. But beyond that, it is not necessary for them to take. Their pain naturally goes away.
Thank you so much, Dr. Ramesh. So the next question is from Dr. Vaidya Vipul Kumar. So what he has also mentioned his protocol. What he said was he gives a combination of Eranda Paka 10 grams at bedtime. He gives Lumbertone capsules 2 BD and Nirgundi Patrasveda with Saindhavalavanam. He's asking if there are any other medicines for quick reduction of pain. Again, it's a similar sort of question, but I think then it is answered.
I think that spray will definitely help as an immediate relieving agent.
Thank you. So next question is from Dr. Geetanjali. So she wanted to know, can you please let us know the medicines used in Churna Pindasveda and the procedure to use at home for patients?
Yeah, we'll give you both. Just note that and we'll share the details with you.
Okay, so just for information, a detailed answer for all the questions asked as a document will be shared after this presentation. So we'll give a detailed write-up on this. So there's another question from Dr. Sudhir. He asked, what are the types of classical medicines that we can prescribe in the management of lumbar pain?
I think I have given that list upfront. In the protocol,
yeah.
I have mentioned what we used to use pre-Lumbertone.
If you could just explain it in a couple of words.
So, again, first consideration is whether there is an inflammatory component or not. In the degenerative component, our primary drugs used to be a Sahajaradi Kashayam. Sometimes we would also add Rasna Saptakam Kwatham with Sahajaradi Avartida. 7 times Avartida Sahajaradi Tailam is what we used to add. We used to give them Trayodashanga Gugulu. That is another thing that we used to give along with that. These are the mainstay of the treatment. Then it will be fine-tuned based on the different situations, plus the external thylums and all that. This is how we used to treat in the traditional thing. Then the other medicines, as I said, if we find there is more ama, then there will be the addition of Rasna Saptakam, Amavadari. We would give them additionally, those days it used to be Yogaraja Gugulu and all that. Post zeotone tablet, we give them zeotone tablets. For it's a most powerful, anti-inflammatory that we have in our weaponry. So that or painflavin, which is the later one. So these two are equally good situations. Of course, if you want to avoid this thing, then maybe Yogaraja Gugulu, but definitely it has got much less potency than this. You will have to give a higher dose of those drugs. Plus, we would give them the thylas or lepas as the condition of ama was to relate to, and that's how the intervention is to be.
Thank you so much, Dr. Ramesh. So the next question is from Dr. R.B. Gojia. There are actually 2 questions from him. One is there any specific consideration in obese patients with low back pain? And the other one is how to manage lumbar canal stenosis with radiating pain in both legs.
Yeah, so first question, to answer the first question, patients with obesity also respond to this, the same treatment protocol, but treating obesity is a lifelong challenge, so we have to educate them and we introduce them while they are undergoing the treatment. What we do is to put them through a weight loss diet. Very important thing is a weight loss diet that we used to advise for our patients, and that helps them. So if a patient is here for about 3 weeks for some other condition, of course, if it is a 2-week program, we have seen up to 2 kg drop per week. So in 2 weeks, we can help them drop 4 kilos, not by avoiding diet. We give them very specific sort of a diet which can help them lose weight. But at the same time,
Again,
they will not feel hungry.
This is something we'll share with all of you if you are interested.
Yeah, if you are interested, you can ask for that. We can share what sort of diet protocol we recommend and we give them to help them lose weight. But if it's already, there are several factors. As Ayurveda says, weight loss is one of the toughest. Nahi stuliste veshajam. So it is not an easy game. This diet, I don't promise to be a solution for all issues, but it definitely sets the ground for it. There are patients who have lost like 13, 14 kilos. Even after going from here, they stuck to their diet plan and they have lost. I've seen patients who have lost 13, 14 kilograms in the process of following this thing forever. That is the most important thing. We can teach them, educate them, but they have to follow even after they go back. Then it is possible.
Yeah, so the next part was lumbar
canal stenosis. Yeah, see the stenosis per se, structurally, if you see, a prolapsed disc can sort of regress again. It can go back. But a lumbar, sometimes the stenosis is of a bony origin. A person is born with a narrow spinal canal. That mostly affects the cervical spine, not so much the lumbar spine. But a congenital narrow canal cannot be expanded with treatment. The ligamental hypertrophy will not suddenly go away. But with our treatment, the disc prolapse will definitely go away. More importantly, the radiculopathy or myelopathy that happens definitely responds to treatment, which means the nerve, in spite of being compressed, is able to heal. This is my hypothesis, because we are seeing the signs of radiculopathy and myelopathy reversing, despite the structure being very bad, which means the body has that phenomenal ability. See, in fact, it is very evident even otherwise, because if you take the MRI of somebody who is like 60, 65 years old, asymptomatic, you look at the spine, sometimes you will think, how is he walking? Because the spine will have so many prolapsed discs and so on and so forth. There will be compression on so many areas, but they are clinically fine. There is no pain, there is nothing. So that shows that the body has a way to adapt to that particular pressure, and it sort of remolds itself. This is the hypothesis I come out with, because clinically this is the reality. I've had discussions with very senior neurologists on this front, where we were trying to do some clinical trials in collaboration with them. So they said, radiological findings are not the absolute truth. Your clinical finding which correlates with the radiological finding only is relevant. So I think renal stenosis by itself, we'll feel it has got a very poor prognosis. But from my opinion, there is a phenomenal improvement that happens in their case as well. So this is what
Thank you.
experience tells me. Yeah.
Thank you. Thank you so much. So again, just to emphasize, any support service you require, please do scan this QR code and fill in the form so that we'll be able to support you.
Yeah, you
Just
can
make
share
it
it in the chat box or chat.
I'll share that link also. So there are a few other questions which I'd like you to answer. So Dr. Vaishali Araj had asked, is there treatment for ankylosing spondylitis and whether we can treat it completely?
Excellent treatment for ankylosing spondylitis is available. As long as complete contracture, complete ankylosis has not happened, phenomenal improvement happens. In fact, I would say we are very, very successful in treating ankylosing spondylitis. There are people who have suffered years and years together and with modern medicine not responding, who have come to us and they have undergone 1 or 2 courses of treatment and they are perfectly fine thereafter. They continue some medicines and all that, but they are not taking any allopathic medicine and they are very well under control. That's a very, very successful area for us in our clinical practice. And we are very happy to deal with that sort of condition. In fact, people, on the modern side now, they are being given biologicals, and it's such a dangerous thing in our country because then they are very likely to get tuberculosis. So we are able to avoid them from taking all those powerful drugs and still keep them fine.
Thank you. And there are a few questions related to knee pain and zeotone and stuff, which I'd not like to address now. We'll send that later. We can respond to that later. So a few other questions related to this topic. Dr. Kali Charan had asked what to do for lock vertebrae S5S1, L5S1. If there is complete fusion, can we manage it? If so, how can we manage it?
If there is complete fusion, it will not change, but they can still be fine. There will be some limitation to the extent of movement in that vertebra alone. See, that is surgically done in modern medicine. If you have a severe disc prolapse and all that, what they do is to do discectomy or laminectomy or whatever. And in addition, they fuse the vertebra also. So that is a therapeutic procedure. The hypermotility of the vertebra is the challenge. If the disc has become thin and the vertebrae and the ligaments are lax, the vertebrae move against each other. That is the biggest problem. So two vertebrae getting fused is not a big issue. But with ankylosing, if it is happening across the spine, there is a problem. And they also have limitation in respiratory muscle movement, which is the challenge with ankylosing spondylitis. But for that, if just two vertebrae are fused together, that happens. Sometimes the L5 is fused with the sacrum. That's called sacralization of L5. Similarly, just if two vertebrae are congenitally or acquired, they are sort of fused together, it's not a big thing to worry about. In fact, they can still be functional.
Yeah, thank you. So next is 2 questions from Dr. Patanjali. One was, does the dose of Lumbarton plus 2 TID cause a lot of heat in the body as it is Ushnavirya?
Yeah, it is slightly Ushnavirya, but even in a place like Tamil Nadu, we are not seeing much of a sort of an issue with that. Of course, there are rarely the patients who have got very severe acidity already, but we have to give the medicine because Guglu is very important as an anti-inflammatory where you need to do the analgesic and anti-inflammatory therapy. We have to use Guglu. So what we do is to add pulsarate along with that.
Okay. And
so
another question
just like in modern medicine now, they are adding pantoprazole. They will give a painkiller or some other drug, antibiotic, and they will also give pantoprazole. So we are not giving them a harmful thing like a pantoprazole. We are giving them a very safe drug which they can use lifelong, which will also improve their general digestion in the form of pulsarate. It's such a fantastic product in helping people, with acidity and long term, not as an antacid, but as something that clearly changes the way the digestive system works. All the gut bud that is happening in the gut system sort of settles beautifully. The ulcer, of course, not everybody might have an ulcer, but even those who don't have an ulcer but who have got the long-term effects of hyperacidity, that is all beautifully corrected with continuous use of pulsarate. So we will be actually helping them solve the other problem also. So if somebody is very sensitive to Lumbarton, it means he already has some level of hyperacidity going. So ideal thing is to also give them pulsarate. This is how I deal with that.
Thank you so much. So the
See, we
next
are
question
sometimes giving, I am telling you, when we are treating patients with avascular necrosis, which is an area where we have become very, we have been lucky to, because of our name, we got a lot of patients initially. And because of our experience, we have become extremely in expertise. We have gained expertise in treating cases with AVN. We have crossed over 1,000 patients of AVN that we have treated successfully now. So we give them extremely high doses of Guglu. We give them 6 tablets of Zeotone plus. We give them 6 tablets of Zeotone tablet. Not everybody, but many patients we are giving them this sort of dose. In addition, we are giving them Lomedes. We are giving them Gugulu Panchabalam. I mean, so Gugulu in so many forms we are giving at such a huge dosage, and they are continuing to take it for months together. Perfectly fine. We are monitoring their blood profile, all the parameters. Their health is booming. The liver parameter, the kidney parameter, everything is tested periodically, and they are doing wonderfully fine. So these are all very, motivating experiences that we have, because we are critically looking at whatever is happening. And so it's very, very heartening to note that our products are so safe for long-term use.
now, doctor from question from Dr. Rameshwar Rao. He is asking, is there anything specific to be done to manage tingling and numbness due to lumbar spondylitis?
Yeah, that is what we are referring to as the radiculopathy protocol. Just Lumbaton plus regularly with some oil application. If they also have diabetic neuropathy, we may have to address that a little bit better. But otherwise, plain due to lumbar spondylosis, if they are getting numbness and tingling, it will go away just with the treatment. It is sure to go away.
Thank you. Then, question from Dr. Ruchi. In cases where MRI suggests of retrolisthesis, what do you address?
Yeah, retrolisthesis, that means they must, I mean, that is just very rare is retrolisthesis. That really doesn't cause too much issue as with anterior listhesis. Because the spinal canal, if it is getting pressed, it is a structural thing, as we said. You can't change that structural thing. Only thing is our posture has to be adjusted accordingly. Other than that, treatment is the same. What I think the treatment is doing is, one, it helps the disc regain its structure to some extent. Number two, it heals the nerves. The most important thing that is happening is the healing of the nerve that is affected by this. So because of that, really it causes a good solution. In fact, I'm seeing somebody put up Agnikarma.
Yeah.
Sorry, doctors, I am not very experienced with Agnikarma. In fact, I would love to learn that from some of you who are expertise in that. I come to know that there's a lot of applications of Agnikarma that is being used, but we are not really using Agnikarma, I mean, very commonly. Definitely not for lumbar spondylosis. We do use it occasionally for calcaneal bursitis and plantar fasciitis, but not for lumbar. We never had the need to use that so far. So I would like to learn from those of you who have the expertise and see how we can also use that in our protocol.
Okay. So another question from Dr. Patanjali himself. So upper limb or lower limb weakness due to canal stenosis or cord compression. Is it ideal for us to refer, or can it improve with treatment?
No, this is actually not an acute situation. We can try conservative management. It again, person to person. I have had one case of failure so far in my experience. That was cervical canal stenosis, extremely severe stenosis in a patient who had recurrent bouts of vomiting and all that. As a result, I was not able to help him with all my treatment. But most other cases of myelopathy, which is what actually happens with the canal cord compression, they improve beautifully. We have seen patients who had weakness in the lower limbs and all that improve so phenomenally. I mean, in fact, I've had conditions where I had to speak to the patient for close to 1.5 hours, because he was a well-read person and his senior orthopedician told him nothing can be done, only surgery is the solution, and he was dead against it. But he would not believe when I said that it is possible. I had to convince him for 1.5 hours, and he was ready to try. And after 6 months, he told me, sir, now I believe what you said, because my numbness is fully gone. With only OP, no inpatient treatment, not even therapy. He only took medicines and he became perfectly fine.
Yeah. So another common theme was, foot drop with radiculopathy pain. Is there something else to be added to the treatment protocol if the patient has?
No. Treatment is the same. We only need to see foot drop. We need to evaluate which part of the neurological system is affected, whether it is upper motor, lower motor, because foot drop is just a symptom. we need to identify what has caused it. Suppose it can be a TB spine, it can be a sort of tumor. So what has caused the foot drop needs to be evaluated very seriously, and based on that the treatment protocol will vary. Sometimes we will have to definitely not deal with that. If it's a TB spine, we have to refer them to the allopathic treatment and stuff like that. So if it is due to just the spondylopathy, that will recover.
Okay. Thank you. Then, so another question in ankylosing spondylosis, when there is restricted
Just a second,
movement.
just a second. இல்லப்பா நான் முடியல, முடிஞ்சா கூப்பிடுறேன்.
So in another question in ankylosing spondylitis, when there is restricted movement, is there something specific to be done to improve movement?
Yeah, they have to do regular stretching, but it will
Some external application or something.
external
like
applications definitely do help. Again, but there we have to be very careful whether we are using Ruksha or Snigdha Prayoga based on the inflammatory status. That is the most important thing to look at. I think we will have a separate session on ankylosing spondylitis because that's a very big topic. I just brushed it in this because the primary thing was degenerative lumbar spine.
And I think many people are also asking about avascular necrosis. So we'll probably
I think we can have a separate session on that. Yeah.
So there's one question from Dr. Kali Charan. He said, we see every day in day-to-day practice that many patients have SLR positive tests. How we deal with this clinically before doing radiological tests? So basically how to diagnose it correctly before doing radiological tests.
Yeah. SLR is only meaning that there is a stretch that is happening. See, SLR will be positive even in piriformis syndrome. Where I didn't talk about that. So piriformis muscle, in some cases congenitally, the sciatic nerve is very close to the piriformis muscle. So piriformis muscle spasm can press the sciatic nerve and cause pain. So your SLR will be positive. Ultimate diagnosis will come only from MRIs combined with clinical examination. I'm not saying this or that. Especially in our country, it is so wonderful to see that we can do an MRI with not too much of a difficulty, unlike in foreign countries. So that's a big blessing that we have, where we are able to really clinch the diagnosis very, very beautifully. But only thing is we must use it. Sometimes an X-ray is good enough, but for certain conditions you definitely need MRI as a diagnostic method. Clinical examination will give you a different dimension. The radiological observation will give you a different dimension. Ideally, we must sync all that. I do clinical examination and I do diagnose based on that, but I also have the luck or the privilege of getting MRIs because most people come to me with MRIs. Very rarely they do without, and whenever I recommend, they are happy to do that. So I personally am of the opinion that, to raise our bar, we need to look at that. But if you are practicing in a very, financially backward community where, the access to all these modern diagnostic tools are very high, then our clinical skill will become more and more. So we will have to, improvise and, try to, because in our Acharya's time, there never was any diagnosis and they treated. But in that setting, even if you were to miss something, it is not wrong. Whereas in a setting where you have access to modern diagnosis, if you don't use it, that is where we are in soup. In a metropolitan city, you can't say, I didn't do MRI because it would cost you money. They will say, who asked you not to? Patients will ask you, who asked you not to give me MRI? Whereas you are practicing in a very financially, deprived sort of a society, then not doing an MRI is absolutely ethically correct. So we are using our best clinical hypothesis and going ahead with the treatment. So that should be perfectly fine and ethical in that setting. Yeah,
thank you so much. So another question was, is there any specific protocol for tailbone pain?
Tailbone pain, coccydynia. My experience is, one, they need to use a coccygeal pillow permanently. At least for a couple of months, they need to use that regularly. Another drug which I have found very effective, in fact, two drugs are, one is Zeotone Plus and the other one is Dhanvantaram 101 times medicated. That capsule is very good for coccydynia.
Okay, thank you. Then Dr. Patanjali has asked, which is better, Kotam-Chukadi Thailam or Dhanvantaram in management of low back pain for external application?
My oil of choice is Dhanvantaram. It does not cause a problem to anybody. Kotanjukadi Thailam is good. It is very Ushna Virya. It is very good for relieving inflammation and all that. Pain relief also is good, but it can irritate the skin of many patients. It's a little too Ushna for for suitability to everybody. So if you are absolutely sure there is no element of Pitta in the patient, we can use Kotanjukadi. There is no harm. But this is more Brahmana. Kotanjukadi is more Langana oil.
Okay. Thank you. And then there's what Dr. Vipin has asked, if we can share more details for Kashayam Vasti and Sneha Vasti to be used in an IP setting. What are the
Definitely. We are happy. Please, tell me what sort of details you want, and we are happy to share that. Yeah.
So, Dr. Vipin, we'll probably create a specific document on Kashayam and Sneha Vastis in the management of low back pain, probably Panchakarma in management of low back pain, and what we follow, and we'll be happy to share that with you. Yeah, I think that that kind of concludes the question and answer session. Again, I would please ask all of you to scan this QR code and ask for all the support you require so that we'll be able to support you further. Thank you so much. I think we are done with the session for today.
Thank you, everyone. Thank you so much for the patient hearing, and let's build Ayurveda to support the community more and more. Thank you.
Thank you so much. So your commitment to continuous learning and holistic healing approaches makes a huge difference in patient outcomes. So together, let's reduce the burden of low back pain in India. Thank you for your active participation. And again, we'll be there to support you throughout your journey. That is what we are here for. Thank you so much.